eruption of the lower lateral incisor, you can start the treatment and define how to fix the crowding. Of course, you have three options: extraction, expansion, or using the leeway. You are in the mixed dentition. There is not only the extraction and expansion possibility, you have a third possibility, is the leeway utilization. Let's start with the extraction. Extraction is not something which belongs to the past. Extraction is fundamental also today. Since we are in the mixed dentition, the right word is not extraction, the right word is serial extraction. Serial extractions is a well-known treatment protocols, which means that if you starting after the eruption of the lateral incisors and by extracting progressively, serially, the deciduous canines, the deciduous first molars, the first premolars, in the right time. Timing is very important. Not before the eruption of the lateral incisor, you have to extract the deciduous canine, but after the eruption of the lateral incisor, and then the first premolar, the sooner you can, in order to allow the canines erupt properly. If you do this properly, you will see the permanent teeth erupting correctly. Maybe it takes 4 or 5 years, but they will erupt much better. Sometimes they erupt almost perfectly without being touched. And in the meantime, you see the patient growing well. Not all the patient, only the patient who needs a serial extraction protocol. Usually they are long faces, convex profile, class 1 patient. If you apply the serial extraction protocol after having done a proper diagnosis, you will see a beautiful growth of the face, of the profile, an improvement on the lips position, and you'll be very happy together with the patient, together with the parents. This happens without touching permanent teeth at all. We know from the literature, this is, in my opinion, the best article published in 1989, that when we apply this protocol of the serial extraction, there is no detrimental effect on overjet, overbite. You don't close the open bite. The overjet can only improve. The marginal bone height, the periodontal health is fantastic, is good, is ideal. And you have a spontaneous improvement by aging better and better and better in the years. These patients were treated 20 years before, provided that specific features have been looked at in the case selection, provided you apply this kind of treatment to the right patient, provided you do a proper diagnosis, case selection, early treatment, and serial extraction in particular is not a treatment which can be applied on a universal application. There are only few patients which can have a lot of advantage by this protocol. In my office, I treat with serial extraction around 20% of the patient in the early stage of the dentition. Even more, you can do an enucleation of the premolars. It means that you extract the primary first molar, and together with the extraction of the first primary molar, the first deciduous molar, you extract the premolar in one time. And if you extract the lower premolars, the sooner you can. If you do an enucleation, you extract the lower premolar before the eruption, you don't see the space between the roots. there is a very good root parallelism without touching permanent teeth. Nothing. No appliances, only diagnosis and serial extraction, in this case premolars enucleation. What are the ideal cases for serial extraction? Crowded class 1 malocclusion with some incisors, protrusion, a tendency to the hyperdivergent facial pattern of growth, long faces, with a minimal overjet and overbite, with a tendency to the open bite. So class 1 crowded malocclusion with a tendency to the hyperdivergent pattern of growth and open bite. These are the patients who can be treated very successfully with serial extraction. But fortunately, 80% of my patients can be treated and must be treated with a non-extraction protocol. A non-extraction protocol means that in the mixed dentition, I will use the leeway and I will expand the arches. Both of these tools or only one. The leeway is what we need, what we know is very important. The leeway is 2-3 millimeters, was measured by Giannelli in the last decades of the last century. These articles are very, very interesting. And Giannelli demonstrated that if you use the leeway itself is sufficient in 70% of the patient to fix the crowding in the lower jaw. 70% of the patient, provided you don't have to move back the lower incisor. If you have to move back the lower incisors, of course, the crowding is much more. And you need more space. Probably it takes some extraction. The leeway usually can be effectively used with a lingual arch. Here you see space before and after, in front and behind the second premolars. This is the leeway after the transition of the second primary molar. The lingual arch maintains the arch length, and here is after the eruption of the second molars, and you see the improvement, great improvement in the alignment of the incisors. You can fix this improvement with a little bit of stripping. So this is absolutely a case to be treated with non-extraction. 70% of the patient can be treated only by using the leeway. You can use a lingual arch, but we can use the leeway also without touching permanent teeth and without appliances. Without appliances means that I can use the leeway, keep the position of the lower molar or the molars, maintain the arch length without lingual arch, without lip bumper, without plates, without appliances. How? I use sometimes the slicing. Slicing means that you can use the leeway where you want, when you want. Slices was shown in the literature by a few articles. If you are interested, just email me. I will send the article to you. And slicing as the aim to maintain the arch length, maintain the permanent molar sagittal position, prevent the mesial shift of the permanent molars, and favor the leeway space utilization, which means you can use the leeway where you want, where you need it, when you need it, and you can use how much leeway you need it. So this is the way I do the slicing. I use a diamond burr, and I cut first occlusally like this, parallel to the distal surface of the premolar, which must shift back in this case. Then I turn the burr and I go parallel to the distal surface of the premolar in order to let the first premolar to go back. This slicing must be in the right direction, must become a sliding surface to allow to let the premolar, in this case, erupt more distally. You have to slice a little bit divergent, parallel to the distal surface of the tooth you want to allow to move in the sliced space. So this is not only a slicing, this is also a sliding path for the permanent tooth. You have to go 2 millimeters below the gingival margin so you see blood, because you want to arrive until the cemento-enamel junction. This is the burr, a diamond burr. This is the direction of the slicing, which is different from the direction of the burr in the picture. You have to slice along the yellow line. This is the slicing. You have to go until the cemento-enamel junction. You see blood. Everything is published on this article. Just ask it to me. And this is the day I did the slicing. What happens spontaneously in the next weeks and months is that the incisor, the permanent incisor, align spontaneously. There is a self-alignment of the permanent incisors. There is a self-correction occlusally and also frontally. No appliances, nothing, only a slicing. Usually I slice only 3 teeth, the lower second molars, the upper second molars, and the lower canines. These are the only 3 teeth I slice. I don't recommend you to slice other teeth. This is the slicing of the second lower molar. It's not a stripping, it's a slicing, you see. It's 2-3 millimeters. It's the full leeway, 2-3 millimeters is the minimum. You go very close to the pulp of the deciduous teeth, and you have to allow the premolar go back. In the meantime, you have to keep the premolar position, and this is what happened. After the slicing, the premolars goes up, erupt. The deciduous tooth is dead. Even if you touch the pulp, it is dead. No sensibility. And the space which will remain is the same space you need for the eruption of the second premolar. You see here, there is no space for the canines. 3-4 years before, I did a filling in order to keep the leeway, in order to maintain the arch length. I did a filling, an amalgam filling, many years ago on the deciduous second molar. Now it's time to cut away a piece of second molar, all the amalgam filling. This is the day of the slicing, a little bit of blood until the cemento-enamel junction. You don't need any anesthesia, nothing anesthesia. You just need abundant water spray, no anesthesia. And the premolar can go back. It goes back, and the permanent canine erupt without problems. This is an elegant way to use the leeway. It is very indicated when you have a tendency to the class 3 occlusion on the premolars and canines. You slice the second lower deciduous molar, and the canines and premolars go back. There was a tendency to the class 3 occlusion, and there is the end of the dentition. In the upper jaw, you do the same. You slice the second deciduous molar when you have a tendency to the class 2. The canines, the permanent canines, are in class 2. So I slice here, the second deciduous molar, in order to allow the premolar, first premolar and canine go back, and in the meantime, prevent the mesial drift of the first premolar. This is the first step of the slicing occlusally. Now vertically, and now the premolar and the canine can go back. The occlusion will help them, will push them back. At the end of the transition, without appliances, everything is perfect. Very easy malocclusion, you can treat it in many ways, but slicing sometimes is sufficient. So the take-home message is, if you are in the mixed dentition, remember that if you don't have to move back the lower incisors, in the 70% of the patient, self-expansion, normal growth of the arches and leeway is sufficient to fix the crowding. A lingual arch and slicing are very effective in the mixed dentition to fix a crowding of the lower incisor in a very predictable way. Also in extreme cases like this, only a lingual arch. But what you get in the mixed dentition is not stable, because after the transition, you will need to face the eruption of the second molar, and the second molar push forward like the first molar, like the third molars. And the second molars will let you lose what you obtained during the mixed dentition. So the magic moment to place the lingual arch is not during the mixed dentition, but is before the eruption of the second molars. Before the eruption of the second molars, if you don't want to lose what you gained during the mixed dentition, place a lingual arch to prevent the mesial drift of and the narrowing of the lingual of the arch length during the eruption of the second molars. And then the story is not finished, because you have the third molars. The extraction of the lower third molars before the eruption could be helpful to prevent the lower anterior crowding, because not only the first, but also the second, and of course the third molars will push mesially, and the arch length will decrease. So it is very diffused. Many people think that if you extract the third molars before the eruption, you will prevent the crowding. Is this true? An early extraction before the eruption of the third molars could be helpful in order to prevent crowding. No, absolutely no. We know from the literature, there is a wide evidence that continuous changes of the dental arches occur from the primary until the adult period. After the eruption of the second molar is the start of an aging process, which will let the lower incisor get more abraded and more crowded. Anterior crowding, especially in the mandible, is very predictable, is a rule, is normal, even if you extract the third molars. In this case, I fixed the crowding of the incisor in the mixed dentition by slicing, only by slicing. It works. But after the eruption of the second premolar, even if I extracted the lower third molars, Becoming the patient older, the lower arch get crowded. This is more or less the rule. Even if you extract the third molars before the eruption, then not only the eruption of the second molars, but normal aging and normal growth, end of growth, will create a little bit of crowding. With a wide individual variation, of course, it depends about many other factors. But this is very interesting, and this article gives you the rationale why, if you really want to maintain the position of the lower incisor for the whole life, you need a lifelong retention, or what you get at the end of the transition. 300 subjects, 3 groups of patients, no treatment, extraction treatment, and no extraction treatment, from 7 years of age until 40 years of age. They measured at the end of the transition the spacing and the crowding in the maxilla and in the mandible. And what they found is that the more stable patient during the adulthood, after 40 years of age, are the patients treated with extraction, the second group, with extraction. Patient treated with 4 extraction didn't show crowding in the upper jaw, nothing at all. A little bit of crowding in the 15% of the patient in the lower jaw, acceptable, a little bit. All the patients treated without extraction showed a little bit of crowding in the upper jaw, the maxilla, and 10-15%, and much more crowding, 28% in the mandible. So if you really want that the incisor don't move after 15 years of age, think about a lifelong retention, not only to prevent abrasion, but also to prevent crowding. So the extraction of the lower third molars doesn't work, is not enough to prevent the lower crowding. Anyhow, are there some reason to consider the extraction of the premolar a good thing? Oh yes, why not? Maybe. Let's discuss it. First of all, what do you mean when you say early? What does it mean early? What is early? How early? Early means before the eruption, but how much before? After the eruption of the second premolar, this is early, but patients are sometimes 12, 13, 14 years of age. The third molar is very deep, not so easy to erupt, to extract, and in my opinion, this is not a good time to extract the third molars before the eruption. Very early, when the kids are 8, 10 years of age, the third molars are liquid, are buds. Here you see very well the lower third molar buds. They are absolutely liquid. And here you see another very interesting thing. The buds of the lower third molars, when the patient is 8, 9 years of age, is not below the occlusal plane, is above the occlusal plane. Above the occlusal plane means that the surgeon have the third molar in front of him, not behind and down, deep behind the second premolar. And if they are in front of him, it is much easier to extract it. So they are above the occlusal plane. The kids are 8 years, 9 years of age, very young, usually during the eruption of the lateral incisor. Here are the buds above the occlusal plane, much easier to make a little cut, 3-4 millimeters, see the bone, make a little hole, see the bud of the third molar, in this case not so liquid, extract it in 5 minutes, maybe less. 4 points, perfect healing in a very easy way. This is the least invasive way you have to extract a third molar before the eruption. Dr. Enzo Rossi is the surgeon who works with me, and this is how he approached the topic of the third molar. This is the patient. You see the buds of the third molars. Above the occlusal plane, a little cut, 3-4 millimeters. Now you have to cut the periosteum. Now there is a very thin alveolar bone above the bud. It is only less than 1 millimeter of bone. Then you see, here you see the bone. A little cut in this very thin alveolar bone with a piezo instrument. As little cut now, this is how the decidus bud comes out. It is a bud, but it is cartilage. It is soft. You can cut it with a knife. And to take it out, it is sufficient to use liquid. And as you see here, you just need a syringe. You can use the last anesthesia you have to finish, or you can just use a physiologic water. So an isotonic solution, and then of course you clean the alveolar, the hole. You have to remove the socket around the molar, the bud, and then just a couple of suture, and everything is done. Treatment time in the hands of Dr. Enzo Rossi is around 8 minutes to do everything. But this is the magic moment when you pluff. Very easy. Okay, there are some contraindications to the very early extraction. The contraindication, in my opinion, are the cases to be treated with serial extraction, with 4 extraction. Sometimes in the hyperdivergent patient, even more if they are treated with serial extraction, we have space. Sometimes the kids are not compliant. They are scared. Don't insist. It is a possibility, it's not a must. But I did it in both my daughters because I think it is an ideal treatment for the third molars. Don't insist to extract the buds of the third molar very early if you are in front of suspicious, hesitant parents. Don't do it. Possible indication to the very early extraction of the third molar are a minimally invasive surgery, the fact that surgery is very easy. This is itself a good indication. When you think that the third molar have a bad prognosis, low angle faces, short faces, and in the cases that you think surgery at the end of growth could be an option, so the third molar must be extracted before, this is the best time to do an extraction it with a minimally invasive procedure. You can do it provided the surgeon is a good one. And Dr. Enzo Rossi is a great surgeon. He has a lot of experience. Only in my office, more than 2,000 third molar very early extraction, with burrs and with piezo surgery. Very early with burrs, with burrs 9.5 minutes, with the piezo 8.5 minutes, much less than the time he takes. Same surgeon, always Enzo, always Dr. Rossi. In his hands, extracting the third molar early before the eruption in the adult takes much longer, 20-25 minutes. No discomfort after the very early extraction, no paresthesia, no just a little bit of discomfort but swelling, no hematoma, a little bit of pain 1 day, a little bit of edema 2 days, nothing. So my take-home message is parents must know very well that the lower third molar early extraction will never will prevent the crowding of the lower incisor. Never will prevent. So provided the parents agree, is there good time, the bud is a real bud, the surgeon is skilled. Treating a kid means a more skilled surgeon, provided it is a right moment, you have a good surgeon, the parents want to do it, why not? I did it in my daughters because I think it's the better way to take out a possible problem. So let's go in these last 45 minutes in the main topic of our today's main topic of the way we want to achieve an alignment, the main way I want to fix a crowding, which is expansion. Expansion, in my opinion, is something different than using these kind of appliances. It works. It's a spring, a quadhelix, it works. But this is not what I recommend you to do. Expansion doesn't mean expansion in primary dentition before the eruption of the permanent molars. This is not what I do. Expansion doesn't mean at all touching the permanent molars. All you see here is wrong. You don't have to touch the first permanent molars. Never. Whenever you place a band or you place a stainless steel arm on the permanent molars, you will not be able to achieve what I want to teach you. You can achieve. Never. So all these things are very wrong. I will talk about this appliance. This appliance means mixed dentition after the eruption of the permanent molars, RPE screw anchored on 4 decidus teeth, 2 primary second decidus molar, 2 primary canines with a little bit of composite. After the eruption of the permanent molars, during the eruption of the lateral incisor, this kind of appliance, a Haas appliance. I started using these appliances in the 90s. This is 1997. Of course, I started using this appliance in the presence of a narrow maxilla posterior crossbite because my goal was to do an orthopedic expansion. So a rapid palatal expansion to fix the palate, the narrow palate, and the posterior crossbite. But I learned in 1997 and in the years before and after that we can do much more. We can fix an aximmetry, you can fix an anterior crossbite, you can fix a recession, like in this case, there is a recession of the lower central incisor on the left. You can fix a crowding, and here the crowding is very, very important. You see crowding in the lower jaw, you see crowding in the upper jaw. There is no space for the lateral incisors also in the upper jaw. How can you fix the lateral incisor? Look at the lateral incisor in the panoramic view. How can you fix it? Impossible. And this is a case who must be treated with a non-extraction protocol because it is a normal, hypodivergent pattern of growth, deep bite. We don't want to do extraction in this case. It's not necessary. The lower arch can be treated only by normal development of the dentition and with the leeway. If you look at the lower arch 1 year before, there is space only for one permanent incisor and two deciduous incisors. This is January 96. No space for the lower incisors. I waited 1 year in January 97. In January 97, I decided to start treatment and I expanded. Same appliance, same what I'm using now. It works the same at that time and now. Nothing on the permanent molars, nothing. Since 30 years, 35 years. In 1994, I published a paper where, and in this paper, I demonstrated that in 21 consecutive patients, I fixed the crossbite in all the patients, and I expanded the permanent teeth 60% of the screws expansion. So the screw expand 10, and the permanent molars expand 60%. All the crossbite self-corrected, all in 21 consecutive patients. So I knew since 3 years, since 5 years, that it works. In fact, the crossbite was self-corrected on the permanent molars, on the permanent left molars, but also the anterior crossbite self-corrected without any other kind of appliance, nothing. And we know now, because we published it in 2012, that also the anterior crossbite self-corrects during the active expansion in the first 2 months when we use this kind of appliance. It is demonstrated in 2012, was published, that the crossbite on the permanent incisors fixes spontaneously in the 90% of the patient. The article is available on the internet, and if you write me, I will send it to you. So not only the narrow palate was fixed, not only the posterior crossbite, not only the anterior crossbite, but of course also the crowding. Space for the incisors. What about the lower arch? January 96, I didn't touch the patient. After 1 year of normal growth, this is the predictable self-expansion of the deciduous canines, the buccal eruption of the lower incisor, a little bit less in this case, there was a crossbite. Then I expanded, January 97, and by expanding the upper jaw, I knew, this is a master thesis published in 97, I knew that there is a predictable little 1-2 millimeters of self-expansion in the lower intercanine width. Then I had the leeway, so I started slicing the lower left deciduous canine in order to fix the midline. And this is the midline, which fixes. Now it's time to slice the other canine. And this is the second slicing in November 97. And now you see there is no more crowding. No crowding anymore. I didn't touch the lower arch. In 1996, there was space only for 2 deciduous and 1 permanent incisor. A lot of expansion. The primary canines still are there, but the lower incisors are aligned without any kind of active treatment. Only the leeway, the slicing, and normal growth. The upper expansion probably helped a little bit. At the end of the transition, a transpalatal bar and a lingual arch with two bands, one on the second primary, one on the permanent tooth, with a little bit of slicing on the lower right second decidus molar, in order to utilize the leeway also in the last period of the transition. And this is after the eruption of the lateral inside of the second molars. The smile is perfect. The smile is perfect, perfect smile line, perfect smile arc. I decided to do a minimally invasive second phase only in the lower arch, nothing in the upper arch. So a minimally invasive second phase. Here is 10 years after treatment. 10 years after treatment. There is a bonded splint on the lower 6 front teeth. This is 12 years after treatment. And one other thing I want to underline is that during the growth, during the transition, you can do the best periodontal therapy you can do, which is place the teeth inside the alveolar bone. The sooner you can prevent dental alveolar compensation, maintain the teeth inside the periodontal envelope, and you will see that also the amount of attached gingiva increases spontaneously only during growth. This was observed in 1991, and it works very well also today. You don't need graft, you don't need nothing. You just need to prevent stupid orthodontic movements, expansion, and to clean, to pull, to brush the teeth properly, and just to let the teeth stay comfortably inside the periodontal envelope. This is absolutely predictable. This is another case. She doesn't have any posterior crossbite. She is a normal transversal occlusion, no posterior crossbite, absence of posterior crossbite, but she is crowded on the incisor. So you have a class 1 malocclusion with no posterior crossbite, a tendency to the lip incompetence due to the slight protrusion of the lower incisors and of the upper incisor, a slight hyperdivergent pattern of growth, but she will improve by growing. A lot of crowding in the upper jaw, crossbite of the upper left lateral incisor, a lot of crowding in the lower jaw, the spontaneous exfoliation of the primary canines means that immediately you have to think about serial extraction. There is a crossbite on the upper left lateral incisor. There is a tendency to a recession in the lower left central incisor. This is a typical case where you must think about treating her with serial extraction. And if you treat her with serial extraction, you have to start with the extraction of the upper decidus canines. What I did, and what I'm doing always in these cases, is not to extract the upper primary canines, but to do something new for many orthodontists, some which is not so popular, some unusual, which is a rapid palatal orthopedic expansion. A Haas appliance, bands on the second primary molars, bonded on the palatal surface of the primary canines, and you can fix 90% of the patient. You fix the lateral the lateral incisor, crowding and crossbite. You fix the crowding for sure, you fix the crossbite spontaneously in the 90% of the patients. This is published 2012, 97% of the lateral incisor crossbite, 87% of the central incisor crossbite. You fix the crowding, you fix the crossbite. Now, after the removal of the rapid palatal expander, it's time to check the crowding. This is the best time to start with the extrusion, with the extraction. But before, I want to show you one very interesting thing. It is that before treatment, there was no posterior crossbite. After the expansion, the rapid palatal expansion, there is no posterior crossbite. The occlusion on the permanent molars is the same despite 1 centimeter of transverse expansion in the upper bone, in the upper jaw, in the maxilla. So no posterior crossbite before, no posterior crossbite now. And here is the head plate I took during treatment, still protruded. A little bit of improvement of the overjet when compared to the before treatment lateral head plate. A good pattern of growth. She is growing in a counterclockwise direction, means she is a good grower. But still, she is protruded. I need space to move back the incisors. So I need something which will push back the incisors, and this is the best appliance you can get to push back the permanent incisor, to align the permanent incisor, is the lower lip against the upper permanent incisor crown. Lips closed. I think that the lips closed is a fundamental appliance to be used during growth in order to drive the position of the incisors. So we work very much on the lips. We work very much to explain the kids that the lip competence is very important, and they must know that the lips competence is fundamental to grow better and to become much more beautiful, and to have less appliances. And they understand and they cooperate. Close your lips. This is what I repeat to my patient 100 times a day. So if the lips are closed, this is the best time to start with the serial extraction, and after you did the serial extraction, you don't need appliance, just the lips closed, and you see how the teeth erupt spontaneously. And here you see the end of the transition. The root parallelism is not perfect, but this is a good enough end of the first phase of treatment. Of course, she needs a second phase of treatment if you want to achieve the best, but many of these patients doesn't want to have any second phase. They are happy like this. Spontaneous movement of the permanent teeth, a very good occlusion, very solid, very stable. A good improvement in the interincisal angle, an improvement in the lip posture. Good grower, great improvement in the lip posture, in the profile. Evident improvement in the protrusion of the upper incisor, and even better after 5 years. No retention, nothing at all, nothing at all. We know that since I did for extraction, the long-term stability will be great in the upper jaw very good in the lower jaw. If you want to prevent crowding, just a little bit of stripping. She didn't want to have the second phase of treatment. I'm very happy because I don't see any reason to do a second phase of treatment in this patient. You know the reason why the patient came to me at the beginning of treatment? Her main concern was the diastema between the incisors, and the dentist proposed to the mother a frenectomy. I didn't do any frenectomy. I expanded the maxilla. I created a big diastema after the expansion, and this is what happened by normal growth. I didn't do any frenectomy, nothing. You don't need it. I expanded the maxilla. I made the diastema bigger. I did a serial extraction. I create a lot of holes, a lot of diastemas, a lot of spaces between the teeth. But at the end of the transition, look, there is no diastema, and the frenum probably was not the main problem of this patient. So, two different patients treated with the same appliance in order to fix the crowding, the anterior crossbite, but in one patient I fixed the posterior crossbite, in the other patient there was no posterior crossbite, absence of posterior crossbite. So, very effective to fix the crowding, the occlusion, the periodontal health, aesthetics, great long-term stability, only a little bit of phase 2 in the gray patient, treated with no extraction, without touching permanent teeth, without cooperation. I like it. A great cost-benefit ratio. What does it mean? It means this is the way I want to treat my daughters. I don't want appliances bonded on permanent teeth. I want to treat my kids in this way. What are the keywords? Not appliance of diagnosis, case selection, treatment plan, timing, diagnosis and case selection, treatment plan, extraction versus non-extraction, leeway utilization, timing, do the right thing at the right time. And of course, you need also an appliance. This appliance is magic in my hands. I can expand the maxilla, and of course, this is an orthopedic expansion. The mid-palatal suture is opening. I do an orthopedic treatment at all, no doubt about it. A huge diastema, they breathe a little bit better. This is orthopedics. But even if with orthopedics, I look for an improvement in the eyewear patency, in the smile width, and of course I gain space for the teeth alignment. Even if orthopedics is something I do in all my patients, at least in the first 2 weeks of treatment. Orthopedics is very important when you want to fix the posterior crossbite, because the molars move together with the bones. But even if orthopedics is something always present in the first 2 weeks, with this patient, with this appliance, I also am looking for a lot of orthodontics, because space for the alignment of the teeth means alignment. The incisors move. The posterior crossbite fixes itself spontaneously. And this is also orthodontics, occlusion. So I move the permanent incisors, they improve the alignment, they find space, and I fix the permanent molars. If you have a crossbite, you fix the crossbite. If you don't have a crossbite, you don't need to fix the crossbite. But what is interesting, what I learned in the last 30 years, what I want you notice now is that the permanent molars expand together with the screw 60%, but sometimes, in many patients, the ratio is different, right to the left. In this case, for instance, the right molar followed the deciduous and the expansion more than what happened in the left. So that I understood that the permanent teeth move independently to the screw. Independently of the screw. We can move the bones in one direction and the permanent teeth in another direction. So when I talk about effects of untouched permanent teeth, I move that we must become able to move the permanent teeth independently of the movement, the transverse expansion of the screw. What happens on the permanent molars? In 1996, we published a paper comparing two groups of patients, a group with a posterior crossbite patient to a group with no absence of posterior crossbite. In the second group, we just wanted to fix the crowding. All the patients came from my office. We published the first paper in 1996, and I treated all the patients of the two groups, consecutive patients, posterior crossbite and no posterior crossbite. Of course, both patients were crowded on the incisor area. The goal was to fix the posterior crossbite in the first group, to fix the crowding in the second group, and we understood 1996 that the permanent molars move in a different way in the crossbite, in the non-crossbite patient, and in a different way when compared to normal growth. In the crossbite patient, in the first month, there is an expansion of the permanent molars, 60% of the screw, and then in the year after, they go on growing in the same way than what happens with normal growth. In the non-crossbite patient, during the first month, I expanded the molars, 60% of the screw, and the permanent molars came back. So this is normal growth. The posterior crossbite patient had the permanent molars growing parallel to normal growth after the expansion. In the non-crossbite patient, no posterior crossbite patient, the permanent molars came back. So I understood that we expand orthopedically the maxilla, we open a diastema, we open the bones, we do a lot of expansion on the deciduous teeth, but the permanent teeth can move, and they often, almost always move in a different direction. So I understood, and am I realizing every day, that we can achieve a beautiful end result by moving the bone in one direction and the teeth in a totally different direction. What we need is to have the lip competence and to have the permanent teeth free to move where they must go. So competent lip and not touching the permanent teeth. When the lips are competent, the tongue must be in the palate. Immediately after the removal of the appliance, when the lips are closed, the tongue must go in the palate. There is no space to stay below the palate. And the second thing you need is the occlusal contact. Occlusal contact means that you want to allow the permanent teeth contact in a way why maybe it takes 1 year, but they will improve the occlusion. So in order to allow the permanent molars to close much better at the end of the active expansion, when there is a scissor bite on the deciduous teeth and a little bit on the permanent teeth, in order to achieve an improvement of the occlusion and maybe a self-expansion in the lower jaw. what you have to do is to work on the occlusion. Working on the occlusion means, first of all, immediately after the active phase of treatment, to remove prematurity, precontacts and sliding precontacts, and allow the permanent teeth to touch very strict in occlusion. So I bring a burr and I grind the deciduous teeth buccally in the lower primary molar, palatally in the upper primary molars, not only to fix possible sliding prematurity, but also to allow the permanent molars to close very strictly. Now the occlusion is working very strictly on the permanent molars. The tongue is very low because in the palate we have the screw, and the lower arch self-expand a little bit. And the permanent molars now, after 1 year, are perfect. So there is no more scissor bite on the deciduous molars, and there is a perfect occlusion on the permanent molars because of the occlusal contacts. So we can achieve a great improvement of the upper arch form, but also we can expand the lower arch a little bit and expect a minimal amount of self-expansion in the lower jaw. Of course, we can work also on the occlusion. By working in the upper jaw, we can change the occlusal contacts, another posterior crossbite in this case. Expansion, of course, rapid palatal expansion to fix the unilateral posterior crossbite and to fix the mandibular asymmetry. But the permanent teeth must be free to move. The result is very stable because I didn't push the permanent teeth where I wanted, but I let the occlusal contact to drive the permanent teeth and occlusion where I wanted, where it is necessary they go. And after 2 years, everything is stable. Well, we have been talking in these 80 minutes about crowding, but before I did an introduction in order to let you understand what are the reasons why we must consider early treatment a very good possibility, a good method, maybe to achieve the same result, but a better method. And so there are many reasons to consider early treatment the best method of treatment in many malocclusion. Many malocclusion doesn't mean in all malocclusion. I gave you some key points to consider: diagnosis, case selection, first of all, and then we talk about the alternative we have to fix the crowding. Extraction, serial extraction, use the leeway, and expansion. Expansion is magic if you learn how to use at the best this kind of procedures, but it is very important that you leave the permanent teeth free to stay inside the periodontal envelope and free to move spontaneously. That my take-home message is that if you have in front of a crowding, lower incisor must be considered a problem after the transition. Because even if you do an early treatment magically, if you don't do a long time retention, the lower incisor will move forever during life. Even if you extract the third molar. A little bit if you do it for a serial extraction treatment, but if you did a non-extraction treatment, the movement of the lower incisor can be relevant. Another take-home message is this: early treatment is not a way to overexpand dental arches. We cannot overexpand. Dental arches grows in a precise way. If we overexpand the lower arch more than 1 millimeter, it will relapse for sure. You don't have to overexpand. You have to know how the arches are growing. And early treatment absolutely is not a way to prevent premolar extraction. If serial extraction, as indicated, this can be the best investment for you, for the patient, and also for the parents. Okay, now we go in the question and answer session, and after the break I will start talking about expansion, indication, when to expand, how to do, so the method, and until tonight we will have a beautiful session talking about expansion. The second part before lunch is expansion, indication and method. But now let me go in the question and answer session. Okay, so I received some question here on my telephone, and now, wow, many questions. So let me read these questions. Oh, yeah. I don't see any question here, Anna. Did you send me the question on WhatsApp? Okay, we will have the question and answer session in 20 minutes starting from now. Yes? Okay, so let's go in the let's go and have our coffee. It is a pity that I can have my coffee together with you, but see you here in 20 minutes. Enjoy the break. Bye.